Going to talk now about the problem of excessive and persistent crying in babies. This is a difficult topic for a number of reasons. Of course, we think of crying as a signal of distress in the baby, which normally, as the child makes the signal, the parent does or the caregiver does something to respond to that signal, and the child is all right and is better, and the crying goes away, which gives the caregiver the sense that he's doing something right. However, when the baby keeps crying, despite having been, as parents tell us, fed, changed, etc., it's frustrating because the parent says, well, I don't know what else I can do to deal with this crying. Another thing that we know is that babies who have excessive crying could be at more risk for maltreatment or shaken baby syndrome, because even the most patient parent, particularly if there is no support, if there is no one to take over when the child is crying and help out and give the parent a break or take a breath or whatever, if the parent is just alone, then it may be so difficult to deal with it that the parent may lose their patience and sometimes spank or shake the baby, as I said. In some cities, in some countries, such as in London, there is a whole network of volunteers that mothers can call when they have an excessively crying baby, and they get support from an experienced volunteer or like an experienced mother who says, why don't you try this, that, etc., to try to give some tips or support to the mother with an excessively crying baby. So this problem cannot be overlooked. Sometimes the pediatrician, with the best of intentions, says to the parent, well, the baby will be okay, he will grow out of this problem, all you need to do is relax. The more tense you become, the more tense you make the baby, and he will cry, maybe because of this. But any mother who has an excessively crying baby will tell you that it is very hard to relax when your baby is crying and crying and crying, and you don't know what else to do. So we typically think of the normal crying, and what is beyond that we call excessive crying. Some definitions suggest maybe more than 3 hours in a 24-hour period of total cry and fuss that lasts over 3 days in a week, and over 3 weeks is considered excessive crying. But in real life, we see babies who cry a lot more than that, who cry almost, quotes, all the time, or who fuss and cry many times a day, or who once they cry, they have a very hard time calming down, and even if they try to do many things, the child will continue crying. Many of these babies are diagnosed as having colic. When the child cries a lot, the pediatrician changes formulas and says, well, this is not the right formula, let's try something else. The parent theorizes the child has lots of gas, that the food maybe is wrong food, etc. And the child goes through several changes. One should remember that colic should disappear certainly at around 4 to 6 months of age. Usually the crying of colic is mostly in the evenings, or a kind of a discrete period of time when the child seems to be overtired, maybe gassy, maybe curves his legs and seems to be in some pain, and it will disappear eventually after a few months on its own. But when the crying persists beyond that, one really is not dealing with colic, although mothers may refer to it as a colicky baby that is a year old. So remember that this puts the baby at risk. Now, crying obviously is not only a problem for the baby, but for the relationship, and one should always, evaluating an infant who cries excessively, look at the factors in the baby, but also at the factors in the relationship and the caregiver. Sometimes babies cry because they are hungry. Sometimes, and the parent may have a very rigid schedule of feeding. So if the baby needs being fed more frequently, that may be one reason for the crying. Sometimes the baby is bored. At times, when a parent is very tired and taxed, they may experience the demands of the baby as very high, and the baby may get bored and need more interaction, and baby may cry as a way to get it. Certainly, as a question of cultural practice, we don't recommend ignoring the baby's cry, although parents worry about whether the baby could be spoiled. Sometimes grandmothers and aunts, with the best of intentions, say, if you pick up this baby, he will be spoiled. We think that the baby obviously doesn't know any other way to call the attention to distress but to cry, and that the baby is not manipulating the parent. But still, parents, a number of parents, a proportion of parents in the US believe that one can spoil a baby in the first year of life by carrying them or responding too quickly. What we tell parents is that we want the baby to think that if they cry and they are in distress, somebody will be there to try to help them. There are several risk factors. One is maternal stress, certainly, particularly during the pregnancy, as well as maternal depression. They have been shown to lead to a higher frequency of babies who cry a lot. We don't know the mechanisms of that, but it seems that the stress and the chemical effects, both of stress and depression, may have something to do with a baby who has more difficulties in self-regulation and who will become more upset. In terms of the evaluation of the crying, one should take into account how long the child cries, how frequently, what seems to make him cry, how intense it is, whether there seems to be pain or not, in which circumstances. In this also we recommend this ecological approach. We try to go to the baby's home to see how it feels to be there. Where is the child expected to sleep, to be fed? Is there a lot of noise? Is there too much light? Is there a lot of people? Is there many pets? There are many possible factors that only when the clinician goes to the home one can evaluate how would it feel to be this baby in this house in this particular situation. Parents may not know to report this to us, and it can only be seen firsthand. Then also one can get the chance to see the parent in action, so to speak. What are the maneuvers that the parent tries to use to calm the baby? And many parents are very creative in reading the child's preferences and signals and so on. So, what are the ecological factors involved in this crying problem? The clinicians should observe the baby carefully during the cry and at different moments. We recommend to look carefully at the baby's muscular tone. How does the baby feel? If you hold the baby, does the baby seem relaxed or tense, arching back? Does he seem to mind when he's touched? Does he seem to be a baby who is sort of fussy and needs to be moved all the time, that wants the parent to get up and show pictures all the time? This is frequently seen in babies who are very intelligent and very easily bored, and they need constantly changing stimulation to be content. One evaluates the baby's attention span and ability to stay focused on things. Then the characteristics of the cry, how costly it is to soothe the baby. One, as I said, could observe the parents' attempts to soothe the child, and the clinician then also could try to do it and figure out how costly or how difficult it is, whether one can rock the baby, move him in space, providing vestibular stimulation, talking, doing some kind of oral stimulation. Does that help the baby to soothe, or even despite this the baby is unsuitable? And then what are the circumstances that may be more associated with the crying? Of course, the clinician should always keep in mind that there may be physical factors, medical factors related to the crying, and one should not overlook those possibilities and collaborate closely with a pediatrician or a neurologist or a gastroenterologist, depending on the situation. The baby may have a gastroesophageal reflux as a cause of the crying. Particularly when severe, it produces esophagitis that leads to pain when eating. There may be neurological conditions such as hydrocephalus, migraines, even in infants. Some other gastrointestinal conditions are also associated with pain. So one should be reassured that there is not a physical problem. We make a great deal of emphasis on the sensory integration patterns of the baby. By sensory integration, we mean how the baby perceives and reacts to the stimulation in the environment, such as, again, the noise, the level of light, the quality of light, even whether it's fluorescent or yellow light. The fluorescent light tends to be more stimulating for some babies. It makes a noise and may be too white and may hurt, literally, the baby's visual system. The same as with the auditory system. If there is a lot of people talking in a room, Nintendo, television, radio, stereo, video games, etc., it may be overwhelming, and many families don't notice this anymore because they are used to a very high diet of noise. And again, only when the clinician goes to the house, one can detect that there is too many things, such as parakeets, dogs, fountains, making noise with water, the radio and the television, etc. So all of this, evaluating how the baby responds to the visual, auditory, tactile channel, proprioceptive and vestibular, the movement in space, helps you to see whether the baby might be a bit too sensitive to this stimulation, and after a while he builds up a level of overstimulation that is possibly released by crying or as a manifestation of the distress. And also, one should always look at whether the baby is having struggles in other areas of functioning, such as sleeping, eating, and their emotional state, which is often the case, So we end up with a baby that not only cries, but also has problems in sleep and in feeding, and that are really a sign more of a regulatory disturbance, maybe of the motorically disorganized type or the hypersensitive type. Of course, if one had a baby who was very sensitive, one can have parents who are able to read this sensitivity, or one may have parents who are not, who may not be aware of this uniqueness in the child. Most parents are very aware of their baby's uniqueness and realize that while child number one was easy to put to sleep and just hold him in your arms and they are so happy, another child may not like to be held in certain positions, may not like lying down, may dislike certain noises, etc., and they adapt their caregiving to those circumstances. But at times, parents just simply don't know that these things are perceived as important by children and may not do the things that are more conducive to the child to be content. Also, Dr. Murray has done some research on the perception of the cry. She calls it the crying is in the eye of the beholder. What does the parent think of the crying? So this is a part of this assessment of the transactional system, which is, does the parent experience the pain as painful? Does it elicit compassion in the caregiver for the baby, or does the parent experience that as aversive and makes him or her angry as a provocation, or as a child wanting to get his or her way at all cost, or being spoiled, etc. This reading and interpretation of the cry puts the child more at risk when it's a negative attribution about the quality of the cry. And again, observing the parent in action, one may see whether the parent intuitively knows what might be the best thing, or in desperate attempts to soothe a child, one may end up doing too much, such as holding, talking, singing, trying to do too much, and the child becomes more and more overstimulated. So, parents differ in their ability to read the child and intuitively do what might be the best. Well, thank you very much.